Morning, everyone. So today I'm going to talk on Tenon's patch graft in management of corneal thinning and perforation and overlay technique. Corneal perforation is an ocular emergency worldwide which requires treatment to prevent complications and to avoid subsequent blindness. This study evaluates the effectiveness of Tenon's overlay patch graft in corneal ulcers with decimetocele impending perforation and corneal perforation. There are several modalities of management, which include cyanoacrylate glue, amniotic membrane graft, corneal patch graft, conjunctival hooding, penetrating keratoplasty, and Tenon's patch graft. This is a retrospective case study of 31 patients, 31 eyes with central ulcers who underwent Tenon's overlay patch graft surgery between July to December 2024 at Dr. Agarwal's Eye Hospital, Cuttack. Of the 31 eyes, 24 had fungal corneal ulcers, of which 10 with decimetocele more than 3 mm, 7 with microperforation and perforation, 3 with sterile perforation more than 3 and less than 5 mm, and 4 with corneal melt. And remaining had progressive non-resolving fungal ulcers with endoexudates hypopion with thinning more than 80% of more than 5 mm, combined with intracameral and intrastromal antifungal injections. Primary outcome measure is maintenance of anatomical integrity of the globe, and secondary is improvement in vision and if any associated complications. Surgical technique is first we give the peribulbar anesthesia, then a thin layer of Tenon's capsule is harvested and it is applied over the perforation with Tenon nylon suture secured at 4 corners. Then it is covered with amniotic membrane graft with fibrin glue and bandage contact lenses placed over it. So this is a case with large fungal ulcer with decimetocele, active endoexudates and hypopion. And this is when we gave intracameral voriconazole with Tenon's patch graft and amniotic membrane graft. Next, the results. At 3 months of follow-up, all the patients had maintained globe integrity with Tenon's patch being taken up and epithelialization completed within 3 to 4 weeks. Subsequent follow-up showed a stable ocular surface and complete healing in all patients with corneal opacity or localized adherent leucoma present without significant complications. 26 patients had more than 2 lines of improvement in their uncorrected visual acuity on Snellen's chart, and 4 did not show any visual improvement, of which after 3 months, 1 needed an optical graft and 2 needed cataract surgery subsequently to regain useful vision. So this is the day 1 post-op, and this is 2 weeks post-op. So I would like to conclude by saying that Tenon's patch graft is an autologous graft which is readily available and inexpensive, fairly less vascularization as compared to the traditional inlay technique. It has no case of graft loss, no special need for HOTA Act, that is Human Organ Transplantation Act. It alleviates the need for therapeutic and tectonic penetrating keratoplasty, and it can convert a therapeutic PK to an optical PK. So this is all about my case. Thank you.
So whenever you finish early, you're in danger of being asked a lot of questions. So in your paper, Ankita, you've talked about Tenon's patch graft, but the technique you showed included both amniotic membrane and Tenon's.
Yes.
Is that right, for all cases?
Yes, yes.
So then your paper itself should be entitled Tenon's patch graft combined with AMG. It can't be Tenon's patch graft alone.
Okay.
So second is that you haven't really given us in your results, you had time. What were the cases in terms of the infections that the patient had, the details of the cases? What was your, yeah, I know I'm not giving you a chance to answer.
Ma'am, I've done in a Excel sheet, but I thought that can be a lag of time, so I haven't presented it here.
All right. And another thing is that what was the primary objective? What was the objective with which you went in to look at this?
That should be the anatomical integrity of the globe should be maintained. That is
Okay.
the primary one.
Okay.
Secondary, we can go for the vision improvement. So first of all, we aimed for maintaining the integrity of the globe. That is the primary
you achieved that in all the cases?
Most of the cases we achieved it.
No, in the results it
Yes,
cannot
it
be.
is. We got a stable ocular surface in all the cases.
Okay. Chalo.
You've presented only one picture.
Yes.
Did you take a photographic
Yes,
documentation
yes.
of the others?
Yes.
Then you should have presented it.
Okay, okay.
And second thing is, you've given only a 2-week outcome in the last slide. So
Ma'am?
in the second last slide, only you've mentioned 2 weeks outcome
Yes, yes.
photograph.
Yes, ma'am.
So
But
at the
we
end, yeah. And then the time to resolution of the fungal ulcer itself, do you think it was longer or shorter in these cases versus those in which
in some
ampulate
cases
glue?
it was longer. In the cases where we have to go for where the perforation was of more size, means when it exceeded more than 3 mm or more than 5 mm, and when there were micro perforations and perforations, so the time of resolution was more.
Is there any study which tells you about penetration of voriconazole or natamycin through conjunctiva versus through cornea? Any basic study that has been done like that? Did you try a literature search on
No,
this?
ma'am, I haven't.
Okay. Thank you so much.